Hi, everybody. We are back again from Dante Pazanese in São Paulo, Brazil. I'm Fausto Ferres. It's my pleasure to be again with MedStream 360. Thanks again to Dr. Samir Mehta, our friend Samir, for this great opportunity. I must tell you that I would miss this meeting again if it had not occurred today. We are always counting the days to be in life again and to show our hospital and our cat. So can I have, can you decrease the return that I have the back here in my ear? Because I'm listening to my, okay, thank you. Much better. Okay, it's my pleasure to have here beside me Ricardo Costa is going to be the first operator for this case. I'm presenting over my other friend here, a great friend, Rodolfo Steig, for many, many years working with us. We also have Louis Nakayama, that's close to me here, and we have our fellow from Cochabamba, Bolivia. Besides him, we have our nurse, head nurse, Fernanda, and all our team here must be recognized to be working with us pretty close. This morning, we're going to have 2 cases. We are in the lab 4 now with all the structure we have here from MedStream. And it's going to be a coronary case. Ricardo is going to show the slides. And after we finish here, I'll move to lab 1. And we're going to have a structural case from our routine. We have done so far many PCI this morning and TAVIs and everything. So this is, again, a routine case that I want to share with you what we are doing here. Ricardo, please, could you present the case?
Thank you, Fausto. So this is a 68-year-old female patient. As current clinical presentation has stable angina, which is worsening in the past months. Now it's class 3 CCS, with a stress positive test for ischemia, scintillography with the overall ischemic burden of 21%. As comorbidities, this patient has hypertension, diabetes type 2, which is also already insulin dependent, dyslipidemia. Her body mass index is 33, so she's obese. And she also has a past history of unstable angina in April of 2022, last year. And by that time, she underwent PCI for circumflex and LED with bare metal stents.
Could you just stop here just to memorize what we found in this history, medical history? It's very important. The patient came to us. Could you bring the camera? Okay, to me, please now. Okay, the patient came to us, this lady with 68 years old with stable angina, but class 3. So minimal 4, she has angina. She has multiple risk factors. What happened to her in the last year was unstable angina, and she was treated in another hospital, the CIRC and the LAD,
yes,
with drug-eluting stents, I suppose.
No, bare metal. Bare metal stents.
Bare metal.
Even though she's a diabetic, yes.
Okay. So that's a bare metal stent. Okay, BMS.
Yes.
Okay. Go ahead. Now we have to, for all the audience, should memorize this. Very important. Unstable angina 1 year ago, and now stable angina. What happened to her in this period, please?
So it calls the attention. You see the listing of the medications here. It's amazing. She has aspirin, clopidogrel, atorvastatin, and then for hypertension, enalapril, atenolol, diuretics, and then also amlodipine, diltiazem for hypertension, and nitrate. She's taking 3 times a day since the last month. And also on the right, the listing here continues for the diabetic, metformin, dapagliflozin, insulin, 2 types, and also she's taking another medication because she had a breast cancer 3 years ago.
So it's unbelievable. So 14 medications. So I take only 3. I have some problem to take all the 3. Sometimes I forget them. This lady takes 14 kinds of medications for stable angina, for everything.
Yeah.
So incredible.
And it's still class 3.
Okay.
And now the lab test, we can see her diabetics is not well controlled, 8.6 glycate hemoglobin. And in the echo that she did also outside here, it shows a apical akinesia and LV function of 54%. If I may continue here, you see this her EKG at this hospitalization. So there's absent R wave on D3, AVF, and also V2 and V3 with some compromise anteroseptal wall. And now we can see the angio which was performed 2 weeks ago as a diagnostic angiogram. We can already see that there's a stent in the mid circumflex AV branch with restenosis, angiographic restenosis. And in the LED, there are 2 long stents. So these bare metal stents were 2.25 by 32, overlapping with 2.5 by 37 in the LED. So it's total of more than 65 millimeters of stents here. And we can see a subocclusion in multiple points. It appears also a minimal flow distally, but we can see that goes up to the apex.
Actually, I think it's total occluded.
It looks like total
in the distal LED.
Maybe some collateral.
There is a correlation with the akinesia in the apex, in the LV.
Yeah.
Do you agree with this?
Agree.
Okay.
Agree. In the mid portion, especially.
Okay.
Yeah. Here we can see the LAO cranial view, the same appearance. And I think you're absolutely right. There's some collateral there in the apex. And here we can see in the spider view, again, is not as bad, but we can see also a diffuse restenosis in this circumflex. Here before was a 3.0 by 18 millimeter stent, bare metal stent that was deployed.
When I look at this angel, makes me remind what Roxana Meran described several years ago about the types of restenosis after you implant bare metal stent. Do you remember that? Proliferative restenosis.
Yeah.
I think this is a proliferate in the LED.
Yeah.
And almost with a total occlusion in the distal part of the vessel.
Yeah. So
I think it's important to memorize this classification bare metal stent. Yeah. I was not supposed we will still have some places that implant a bare metal stent for.
Yeah, it was type 1, 2, 3, and 4.
Yes.
Type 1 and 2 are focal, multifocal.
Yeah.
And then type 3 was a diffuse, but within the stent.
Yeah.
And the type 4 was total occlusion. So it looks like LED, we might have type 4
diffuse,
and type 3.
Type 3 diffuse proliferative.
Yes.
So the chance of recurrence, it was 80% if you do only balloon.
This is really going to be a unique platform. People will be able to tune in and see interventional live cardiology cases from around the world performed by some of the world's best operators. The real advantage of this is that they'll do 9,000 cases spanning the whole spectrum of interventional cardiology.
For MedStream 360, we'll be extending 24-hour live cases so that you can watch cases in your own time zone, time frame at your own convenience.
MedStream 360 is a transformation in medical education. With MedStream 360, you can see wherever you are, in your office, at home, in your computer, in your iPhone or your laptop or your iPad, any case in any topic whenever you want. And not only that, you'll be able to see the best operators from around the world sharing their live cases with you.
There are several unique attributes of MedStream 360. We have no moderation and there is no time restriction. The majority of the cases, an overwhelming majority of the cases, are viewed not live but archived cases. So to enhance your viewing experience and to customize the archived cases to your requirement, we have assembled an army of physician video editors who have been experimenting with different formats. All of this is being done to enhance your experience and to make MedStream the most beneficial.
Concept here is to provide easy access to more live demonstration cases to more physicians. I think live demonstration cases are probably the best way to learn the nuances of our field. And the more we can do to bring cases of interest to our community, the better we'll all be. This is a great way to exchange information and to keep up with the latest in interventional cardiology, period.
So I look forward to welcoming you to MedStream 360, and please give us your feedback. We hope you enjoy it as much as we're enjoying putting it together. Thanks very much.
There's a case of 104-year-old plus female with progressive dyspnea and for last few months, and has a non-ischemic cardiomyopathy, has other conditions. And we did a widen heart failure back in July, had a balloon aortic valvuloplasty, good medical therapy, and here with a severe calcific aortic stenosis with intermediate degree of CAD, which has been managed medically. So this basically a CTA, aortic annulus. Gilbert, you want to comment on how things are here?
Yeah, I mean, this 104-year-old clearly has a small aortic small annulus. You can see mean diameter is a little bit over 21. Areas on 340, but very horizontal root, 80 degrees, so it's almost vertical in terms of the annular plane. Next slide. And you can see the sinus is also very small. You can see around 25, 26. ST2 is also very small, 23. The left main and right coronaries are quite high, so there's not an issue in obstruction. LVOT is also very small, around 21. Next slide. I think Sahil can comment on the access, and we will show you some live angio as well.
Yeah, I think access is very challenging here. There's tortuosity as well as calcium all across the medial and the posterior wall of the vessels. The left is reasonably sized, but there is an area which is calcified, and narrowest is 4.4. So I think this will require balloon angioplasty before we go in with our 14 French sheath.
Okay.
Yeah.
And then this is about sentinel issue.
I think Sentinel is not possible. It's very tortuous. I think the risk of trying to navigate that tortuosity, you're trading off stroke because of manipulation of the Sentinel in those vessels.
Go to the fluoro, please.
The main access will be from the left side. They already done the PTA for the left side. So we have a pigtail on the right side. So I think the plan would be that we are going to say, you see the tortuosity.
Yeah, this is it.
So we just dilated once, already PTA done. Goal would be that we have a pigtail, we'll leave a Lunderquist on the non-access side, and then we'll plan. This is the Lunderquist that will straighten the vessel. Good.
And just to say that a lot of people do use Lunderquist for the valve deployment. I would say probably in a 34 Evolute might be have some role, but we felt that it's a very aggressive wire and cause some dissection, perforation. So we don't use Lunderquist routinely. Here we are using it on contralateral side to straighten out iliofemoral and distal aorta. And of course, still they've done up some PTA already, but still need to do further.
Which balloon was used for the PTA?
6.0 Armada balloon.
6.0 Armada, yeah.
Yes. Okay. Yeah, the calcified segment is around 4 and 5, so it's very small.
And you got good expansion on the balloon, on the inflation.
Yes.
Now, what about using the IVL? We have done some cases. In this particular case, maybe both Sahil, you can say that why not IVL to give a little extra leverage in terms of fracturing that calcium of the calcific iliofemoral area.
I think, Dr. Sharma, IVL is good if there's a lot of medial calcium.
I see.
This one was not circumferential, it was more patchy and very thin layered. So I think we can avoid IVL in this case.
What's the angulation?
Plus there are cost implications of...
Yeah. Okay. So this is going there now. What sheath it is? Anybody comment?
14 French Edwards.
14 French Edward sheath.
Very nice.
Okay.
When we tried it first time, we had some issues. That's why we pre-dilated with the 14 French sheath and then this Edward sheath.
And another issue is that you see the abdominal aorta is completely calcified.
Yep, very calcified.
That is the challenge to navigate the tortuosity as well. And that's putting another stiff bar on the contralateral side helps with the tracking of this particular E-sheath.
So basically use a body wire there to
That's it.
facilitate.
Yep. So many of our techniques of the coronaries are used for to improvise. Come here. And tie her back.
Now, with this extremely horizontal valve, Dr. Sharma and Dr. Kini, you expect resistance for the S3 to go through?
Yeah, I think we expect resistance in anything for this particular case.
Exactly.
But the way things are, since the sheath is there, and it is a challenge in all throughout, but our goal is here to show our audience the challenging case, because otherwise tower, as we all know, has become a routine. 712 centers in United States, and last year's number may be down than a year before because of COVID, although maybe still high because only growth which we had even in the COVID era at Mount Sinai was tower. 370 versus 318, 370 in 2019 and 382 in last year. So that's the only thing grow. Everything else has a 16 to 18% decline. And the national number we do not know, but we know about 70,000 plus in 2019. So key is that this case is very challenging. Now, whether this makes it to the history in terms of the oldest patient in America, I don't know. But we expect to write the case report. We already spoken to our fellow. And as I mentioned, that we looked into the literature, and we could find only 102-year-old patient having the tower in United States. Published literature. We do have published in 2004 our BAV article where we have patient up to 104, which we did the BAV.
Very nice.
Okay, tell us, Anu, what did you use to cross and what catheter?
AR2 with the straight Terumo wire.
Yeah. Okay, and what is the plan now?
I think we'll exchange it to a pigtail,
Okay.
then change to the tower wire. We can show the gradient here.
So it's still quite a high gradient. So clearly that we have a clear indications in this particular case of and meeting all the demand, all the gradients, the quality of life and all those factors. So therefore, appropriately indicated will be fall into the DRG. Okay. So this is
Very
now
good.
being changed. The AR2 is being changed to the pigtail, and now we are going to use the safari wire.
It's a small LV cavity, that's why we go with the safari wire here rather than the usual confidau that we have used in a few other cases.
Now we have no blood pressure measurement except by our anesthesia team. They have the measurement of the blood pressure. Okay, it's on the pump. Yeah. Only thing we are just not showing it. Okay, we are ready with the balloon. Okay, what size balloon we are doing? 18.
Yeah, and give
18
another
will be enough
250
give.
fluid, please. 250 cc.
We are actually same that we want to be conservative little in this particular case with all valve sizing, balloon valvuloplasty and so. And we are 18 with a syringe attached right there. Good. And valve should be ready in case severe AI occurs, which occur in a small percent of cases. Good.
Yeah. So that feeling, Dr. Kinney, right there, you felt resistance or not much?
No.
Yes.
You felt it?
That's the key.
Good. Fine.
It's like,
Yeah, but again, the gradients were there and some fracture of the valve has taken place by our earlier BAV.
yes. Would you daughter again, or you just go ahead
No,
with
just
the
I
valve?
think one shot, as long as you have done one and knowing that, yes, if I'm doing a standalone BAV, I will do a one more dilatation. But since this one, we are all good. So there's a 20 millimeter nominal volume.
Yep. Check orientation. It's checked.
You'll speak for orientation.
Orientation, okay.
Okay,
Looks
the
like-
operator,
Yep,
first
it was low
operator
movement.
checking the orientation,
Orientation
confirmed by
confirmed.
me.
Skirt is ventricular.
Good. Leave it.
Who's holding the wire?
Me, I'm holding. Go. The sheath may still give little resistance. Good. Coming slowly and slowly.
Okay, good. Okay.
Good. Okay. Now show what we are doing here. We should be on fluoro and manipulate.
That's the wire.
Yeah. So putting the stent on the balloon or the valve on the balloon. Yeah, valve alignment. Good.
Let's take this supracore out now and put the pigtail set up so we're ready to go.
Let's cross.
No, there's
now.
no. It won't matter.
I don't think so. I got the. That's
Good.
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 Keep going. Advance.
Okay. Now we are advancing and rotate.
You can see how horizontal the aorta is.
Good. We are in.
Almost 90 degrees. I'm going to the angle now.
Yep.
Advance the
watch
wire.
yourself.
Advance the wire.
Yep.
I'm going to bring the hypotube behind, back.
Valve has come out a little bit, which is okay.
Okay, that's good.
Let's
Okay, you're good.
magnify in
Position
now.
is.
Yep.
Yeah. Good.
Okay. It's pretty good there.
Let's
Yeah,
do it.
Yeah, it's a lot of AI.
Test.
180.
So we always check at the hype pacemaker that your valve is
Okay,
where
stop.
it should be.
Yep. Okay.
Good
Yeah,
spot.
good spot.
Everybody agrees. So pull
Yeah,
back
go
the
slow.
pigtail.
It's a little high on the versus the left, so just go slow and self-centered.
Good.
Yeah,
Okay,
flex it.
180.
What do you want now?
No, that's good. Okay, just
Okay.
want to check.
Good. Okay, we are going up now. And we tell our anesthesia colleague that we are going up. So just loud so everybody is on the same page.
Okay. Yeah. Now it's
Yeah,
capturing.
good. Capturing nicely.
Okay, I fully inflated at 6.
Good.
Stop
Okay.
pacing. Please resuscitate.
Good.
Okay.
Keep it there in case we have to add some extra fluid.
That's it.
No need.
Let's take an
No, but
aortogram.
we'll see. I'm saying that
Yeah.
we have the capacity here. If need to be, 1 or 2 cc's can be added on.
1 cc.
We are on the
Okay, let's-
minus
It's okay. No.
side. Yeah. Okay.
Yeah.
Pressure is back. Hemodynamics you are seeing. We are ready for the aortogram. Good. Got a pigtail. We'll do a hemodynamics if
Inject.
necessary. Yeah.
I think a central AI.
Central.
Is it? So
Yeah.
I want to
Yeah.
confirm with the echo.
Okay. Yeah. Malcolm and Stam.
Look at the pressures.
That's good.
Okay. Show the echo please on the screen now.
Yeah.
Live echo.
Central AI, the function is good.
Did the LV improve a little bit? I know LV has been on 25, 30.
Yeah, minimal paravalvular, minimal PVL
It's okay.
to the apical views. But you can see nicely the views, this 3-chamber view. Yeah, no much AI,
Okay.
minimal PVL, and some central aortic.
Good. Okay. So we are going to do hemodynamics and then we'll take the hands out and then we are going to take the wire out and then reconfirm the.
And no effusion, no pericardial effusion.
Yeah, diastolic pressure is pretty good. Huh?
Pretty good. Yes.
The patient requires some sort of epinephrine, or is this her normal pressure?
Caesar, did you give any visual pressure push earlier or nothing now, right? No. Okay. We have to flush the femoral as well as. Good. Okay. Let's see the
Look at that.
hemodynamics.
Beautiful.
No gradient. And diastolic about 80. Beautiful.
Yeah, there is.
Fluoro, we can pull back. And then we are going to do fluoro. Okay. Now we do aortogram now again without the, because it was central earlier. Yeah. Good. Ready? Yeah, here. No? Okay, echo team, please.
Yes.
Repeat. Go to live echo. So it looks like 1+ here, but there is very high blood pressure right now of about 180.
You see? Yeah.
We just need to concentrate on that central AI now.
Yeah, it's not much,
Good.
It's minimal PVL, at most mild valvular, at most.
Okay. I would say the mild is a winner in this case, considering all the facts. And you saw that how we were able to implant
Not
in
much.
this horizontal aorta our Sapien 3 Ultra valve,
Yeah.
20 millimeter.
Not much. As you can
Right.
see, minimal
Minimal.
PVL, and yeah.
Okay. So now the whole question will be, Sahil, tell us what will be your access, what you are going to do from the access point of view. Do you have a contralateral wiring here, or what will be the goal now?
Can you lower the pressure, please? We're
Okay.
closing.
There is a plan for bailout stenting, which we had already decided. If we had discussed with the patient's family that if need be, we'll do bailout stenting. I don't think we need to. We have got a good stick, so with just balloon angioplasty, we should be okay.
Okay. So what we will do is we go back to now, Pedro. Any other questions from your side or anyone? Then we go to our presentation while we'll do a live closure with all the fellows and with the Sahil and our team.
Yeah, I think we're good. There's no questions from the website.
Meio
So
e 275.
Não tem 2,30?
2,30, Rick.
Pega o 30.
220.
Pega o 30 logo.
Pega o 30 e já
É que vai ter
libera
que usar 3, André.
Mas
Então,
tudo bem. Bota um Valep ali, não tem problema.
Então tá. Pega o 230, por favor.
30, 30, 30, 30, 20,
algum
20.
sinal, Heitor Fausto? Estamos ao vivo.
Então pega o 30, 20.
We're not receiving feedback here in the audio.
Okay, great. Okay, so we are back here again. We are sorry because of this technical problem we had in the system. It seems to me it was because of the Zoom. And I'm gonna ask Ricardo just to
Summarize
summarize the case, please.
Yes. Okay. Can we have back the slides, please? So this is the RCA. The RCA is a diffusely diseased vessel with subocclusions and action occlusion distally. This one was already described in the angiogram. It was done last year. And they decided by the time to keep this patient in conservative treatment for the RCA. And finally, the LV function, we see a preserved LV function, some mild akinesia in the very apical, inferior apical segment, but a completely normal LV function here. So what we did, Fausto, we discussed this case, and this case was obviously not an option for surgery as having a full metal jacket in the
Okay,
LED.
may we have all the camera here and we can discuss about it?
Yeah.
Please.
And then there was,
Okay.
considering her clinical symptoms very limited despite the optimal medical treatment and preserve LV function, there was a consideration to try to revascularize all the vessels.
Okay, great. So we have a patient with segment with stents about 69 millimeters in the LAD with an in-stent restenosis, a proliferative in-stent restenosis, if you can just understand me, in the LAD. And we have, I would say, a focal restenosis in the circ. And we have a diffuse disease in the right with total occlusion in the distal part.
Yes.
With a normal LV function. So we should decide what to do in the patient like this. Would you send this patient to surgery? How about you, Louis?
Yeah, I would consider at first when we start to using a barometric stent. In this case, we should not use a barometric stent in a diabetic patient. And I think, but now we are having like 69 millimeter stent. I don't think we have anywhere we can do a LAD, so you can put the internal memory here. So I would go through procedure and interventional.
Okay, but we have a triple vessel disease in this patient, Rodolfo. Triple vessel disease is clear. Diabetic patient. If you go to the literature, maybe you should send this patient to surgery. Why not?
Maybe in this case, because the diffuse disease in LAD.
Okay, because of the distal bed.
Yeah.
Yes.
We cannot fix internal memory in the LAD.
Yes, it's anatomic.
So that for an anatomic reason. Yes. So for the audience to understand this very well, this patient has diabetic. Possible. We discussed the case with the surgeon, and he refused for surgery. And we also, as a clinician, cannot indicate surgery for this kind of patient because there is no place to insert internal memory. Do you agree with Ricardo?
Absolutely. And also the distal bed in the RCA, it was not, probably not feasible for SVG there.
So
suitable.
In this patient, there is no option for surgery. We don't need to calculate syntax or syntax score or anything like this because there is no indication for surgery. So in the medical management, only clinical treatment, there is no rule. This patient is taking about 14 kind of medications and is still with class 3 angina. So there is only one option. to treat with coronary intervention, percutaneous intervention.
Yes.
So what you have done so far, or what are you thinking how to treat this patient with this diffuse in-stent restenosis? You have the right, you have the circ, so you have a lot of things to say.
And a very light ischemic burden. So we wanted to provide the best complete revascularization as possible, despite diffuse disease. So if I have the slides, please. So last Friday, this patient was brought back to the cath lab.
You have the slides? Great. Next slide, please.
And we decided to treat the RCA, as you can see here.
So 4 days ago, or 5 days ago, today is Wednesday, last Friday, what you did?
We tried to recanalize the RCA. It was a little challenging to like an occlusion already in the distal portion, but we were successful. We pre-dilated and we deployed 2 stents, the true sirolium Zeluni stents.
Did you do this case by radial?
We did by femoral. Procedures.
So this is very, very common in clinical practice. This patient was treated last year by radial in acute coronary symptoms. There is no pulse in the radial artery anymore.
Exactly.
So if you remember, this lady is she's obese with MCI of 33.
33.
So usually the radial artery is so small and can use only once.
Yes.
Now you did the right intervention by femoral.
And we have a stent in the deployed in the mid portion, and then a stent deployed in the distal portion. These were serious stents, and then you can see the distal bed was recovered. And despite the diffuse disease, you can see in the proximal segment, we thought, we should only have more spot stents there to not blind all the RCA, and we are satisfied with this result. So
it was a good preparation to do a hard work in the left system.
Yeah.
So you did that in a complex lesion at right. You treat with 2 drug-eluting stents. Do you remember the stent length for both?
Yeah, it was 18 and 20.
In the right.
Yeah.
So the patient came back to treat the left system. So what you were thinking to treat this patient, Ricardo?
Yeah. So if you could have the angio, we
may you have the angio now?
The angio, please.
So the first image.
So this is the first angio we did today. You can see, and I think you're right. It's like an occlusion in the LED, and that's a normal LV function. So we wanted to try, despite very challenging anatomy,
Did you see any
recanalize the LED.
Did you see any collaterals?
Just some ipsilateral collaterals coming from the circumflex, but not from the RCA.
So sometimes it's very common when you have a very tight restenosis after a stent, and like we saw, we don't see some collaterals, but the patient has still viable myocardial in the anterior wall and with angina, like we see in this patient, the class 3 angina. So that's a very complex LED.
Yeah,
so what do you
and
need?
We have here a 32 plus 37 millimeter stent.
So are you using a 6 French or 7 French, guys?
I'm using a 6 French.
So can you show just the femoral artery, what you did, please? With the camera in the femoral artery, just to see. So
to show here.
You start with guide wire. What kind of guide wire you choose?
Yes, so we're using the IVU 3.5, 6 French.
Okay, the femoral artery, please.
And we went to the left femoral.
Okay.
Okay. We have a second.
So you avoided to do a puncture in the right because you did it 4 days ago.
Yes.
And now you are treating in the left.
With the
left femoral artery.
Yeah, it was.
So what kind of guide wire you choose?
So the guide wire, the 0.014 inch, we first
was a polymeric or non-polymeric?
Non-polymeric.
Why do you use a non-polymeric?
We thought we could go through the stents, and despite the aspect, having hyperplasia, sometimes
can you
goes
show us how
here.
did you across this lesion? Did you film? Did you record this?
We did. So here.
Okay,
this
good.
is what we try first, and we cannot
Is there any specific maneuver to get across for this very long lesion?
Yeah, you should try not to have a very angulated tip, because you're going through a hyperplasia, You have the stents. There is a straight segment. It can slipper well better if you go
Let
like
me
this.
ask you, Rodolfo. Rodolfo, when you go with a guide wire and an instant restenosis, is there a chance to go to out of the wall to get a dissection? Although we have a stent there, could you?
Yeah, if there is a total occlusion, it's possible.
If it's possible. We cannot forget that. It's a very important lesson that Rodolfo is giving to us. Although we have a stent in the artery, sometimes you can go through the struts and get a dissection outside.
Behind the struts, and you can do a dissection in the...
Yes, behind the struts.
Yeah,
Perfectly.
And here, at this point, when we try to force a little bit, he started to go out of the stent. So we decided to stop here and then to change for a hydrophilic wire.
Why did you change?
Because we cannot advance here anymore.
Okay.
So, and we have a support from a 1.5 millimeter balloon.
So, if you had a chance, would you choose a non-hydrophilic wire?
By first choice, probably.
Okay.
Fausto, look at the tip of the...
Okay. The balloon.
You see?
Yeah.
Yes.
It's coming to out.
Outside,
Okay.
behind the struts.
Behind the struts.
I didn't know what we were doing because I just came, and someone told me, my spirit maybe, told me something like this happened. Yeah. So, and what you did now?
Here you have to be very careful and just make sure you are in the right place. So next one. Next one.
Next, please. Okay.
So here we
so always when you have the balloon close to the tip of the wire to give you some support and you can get across a long lesion like this.
Yes,
it's very important.
Just keep advancing
so
to have a better support.
Okay.
So see, you can go. We could advance here.
Okay.
More to the distal end of the stented segment.
Okay.
Next. And here we already changed the view because you want to see the distal bed.
Why did you inject dye contrast in this?
Because here I want to see the distal, the whale tail, and I can see the whale tail there, and that's what I wanted to go. I want to make sure that's not a total occlusion there.
So it was a long segment.
It's a long segment.
I agree with you.
And in the cranial view, you cannot appreciate that, how long it is.
That's what's a good choice. So you change the view for the RDO because it's much easier to see the artery in the distal part.
From the apex.
And our target was to go to the whale tail there, one of the branches there. Next.
Okay, can you go again, please? Next. Oh, great.
So now
I like that.
We were there, and then we
inflate the balloon.
Yeah, we went first with a 1.5 balloon.
What? A 1.5 balloon?
1.5.
Okay.
Because a very, very small distal vessel at this point. We want to make sure that we're not causing any injury here, not dissecting, not perforating. And we went through the whole stented segment.
So it's 1.5 by 12 or by 18?
By 20.
By 20.
By 20.
Okay.
And at this point, we could recover the anterograde flow despite the distal bed. And now we are ready to do something very important, which was to go with the intravascular imaging, in this case,
look at the
IVUS,
distal,
to try to see the mechanisms involved in this restenosis.
Okay, so you did already did the IVUS?
We did IVUS.
The wire is not in the true in distal part yet.
Yeah, we did what we did, Fausto. We reached the distal part and we tried to exchange the guide wires here.
Okay,
so that's
here we can see.
Okay.
Yeah, here's the whale tail.
Okay, so you did do the other direction.
Yes, the other direction, and then there, parallel guide wires.
And at this point,
so what kind of guide wire you choose?
Yeah,
the first one you use it, or we use the third one?
We have a hydrophilic. First we went with a BMW, so it's already open. It didn't go through. Then we went with a pilot.
Okay.
And we went through. So we didn't want to keep working because the tip of this wire, you're very distal, you can cause perforation.
Yes.
Wire perforation.
You change again for the first one.
We went back with the first wire.
Great.
And it went very easily.
This is another important lesson to avoid a complication in a case like this. He started with a BMW. And after he could not cross, he moved to a pilot one. And he could cross, and to avoid the perforation in the distal part of the artery, he came back with a BMW. So it's a very important teaching in this point.
And we're much more comfortable to work now.
Now?
And then we did after the predilatation, we did the IVUS.
So you have the image?
We have.
Could you bring the IVUS image, please?
Começar no distal, Wagner.
In the big screen, IVUS.
Yeah.
The big screen. Only the big screen, please. just to take a look. So we are going to start a run in the distance. So it's going to be a long run.
Very long run. So here we started distal to the stent, the very distal LAD.
Okay.
You can see it's about 2.0 vessel. We already see some diffuse here. This is a stented, the distal edge of the stent is about 2.0, I would say 2.1 by IVUS. Remember, IVUS tends to overestimate by 10%. And we start to see the hyperplasia here, not compromising very much the vessel, the lumen vessel.
Do you think the stent is well expanded?
Yeah, here we're going to start to see some spots. I think it's a little bit undersized. The vessel is larger, it's about 2.5, 2.7 at this point, but it's a lot of plaque burden, of course. And there's some spots here of underexpansion compared to the more distal portion. Now, as we move more towards the mid portion of the stented segment, we see diffusely a presence of hyperplasia here. And this is after post-dilatation, but it's better expanded at this point. And we're going to see that this distribution of hyperplasia sometimes is more concentric, sometimes more eccentric. We don't see signs of funny things like macrophages and things that we see nicely by OCT. So it appears to be a regular hyperplasia. Now the vessel gets larger, is about close to 3.0, but the lumen is about 2.5. So I think the stent at this point is a little bit undersized and a lot of hyperplasia, diffused hyperplasia. And here we can see how undersized to the EEM it is. There might chance to have some positive remodeling as well. There's some calcified spots here, more underexpanded. But I wouldn't say, Fausto, that the main mechanism here is underexpansion. I think it's intimal hyperplasia with the bare marrow stent in the insulin-dependent diabetic.
And how do you think the underexpansion can play a role in this case? Just no?
Yeah, I think it can. There's the spots of the underexpansion. Sometimes is where you see the minimum lumen area, but as I mentioned, I think that's not the main mechanism for this proliferative restenosis.
So, as a recommendation for in-stent restenosis, we need to use IVUS to identify the mechanism of the problem. So, the mechanism here is predominantly intimal hyperplasia.
Exactly.
Do you agree with this?
I agree with this.
So,
and that's important information.
So you have a long segment with stent, a long segment with in-stent restenosis. What is your decision now? You have 3 options. I'll give to you. Can you bring the angel now, please, to the screen?
Yeah, and here just to say it's a diffuse disease, but we don't see any more important spots.
So can you stop with the balloon, the plain old balloon angioplasty, the POBA. You can go further and implant maybe 80 millimeter stent now, or even more, longer than this. 80 millimeter with a drug-eluting stent, since we have a in-stent restenosis in a bare metal stent, or should we choose maybe a pharmacological balloon, a drug-eluting balloon, to treat this?
Yeah.
Do you have a choice?
In this type of restenosis, if you use a regular balloon, even though you can achieve a good result acutely, the chance of restenosis can go like 60, 70, 80% because a very long vessel and very small vessel as well.
So you eliminate
I eliminate that.
Do you, both guys, do you agree with this?
Completely.
Okay,
Completely.
Rodolfo and Louis agree with this. We should not treat this patient with only a balloon, although you have long. Yeah. So next option, drug-eluting stents.
If I go with drug-eluting stent, there are some studies comparing a drug-eluting stent and a drug-coated balloon. You can have a better result in terms of late loss with a drug-eluting stents. However, very long segment, a double layer of stents. This patient already did not responded well to stents, and you have a very caged vessel that we don't think that's a best option as well. If you can avoid that with some other option that avoid to put more metal, we think is better.
So you eliminate these two.
We eliminate two.
Not eliminate, but not the first operation.
No, it's not
as
the first
intention,
option.
as
So
intention.
if you don't have a drug-eluting balloon, maybe you can use a drug-eluting stent.
It's not.
Yes. It could be, even it's easier. If you play say, a stent, a long stent, you can get a long stent or maybe 2 long stents, and you solve the problem. So your choice is going to be a balloon. So as you needed to do a better preparation now
Yeah.
with the planoidal balloon. What you did so far?
So what we did here, let me just advance here. Drug-eluting balloon is just a delivery of the drug, so we have to achieve a good result with balloon angioplasty.
Mm-hmm.
And we went first with a non-compliant 2.0 by 20 millimeters.
Okay.
And we went
so we
to-
start just for the audience. We start with a 1.5. You did a preparation for IVUS. You did IVUS. You bring a 2.0 balloon. Could you bring a 2.5, or do you think the vessel was too small distal?
The very distal 2.5 will be too much.
Okay,
so we went to 2.0.
we cannot oversize the balloon in a case like this, mainly because of the distal part of the artery. Okay, you choose a 2.0 balloon,
2.0
non-compliant,
non-compliant.
by 20.
Because non-compliant, you go to high pressure. You can also
You need high
better
pressure.
expansion.
Okay,
Better expansion.
What kind of, how much pressure did you use?
25.
25, yes.
25.
So it's very important. We use, mainly in that point, we saw under expansion stent by IVUS. You use a 2.0 balloon with a 25 atmospheres. Great. Can you see the results?
Here distal, here more
Yes.
proximal, and then here we went with a 2.5 by
Okay,
20.
can you go back just to see after 2.0?
Because
Okay.
the
You
end-
still don't have distal flow.
No.
Okay.
Yeah.
But the arteries looks better, but not as good
very
as
small.
we could
It's
expect.
some spasm.
Okay, spasms, some spasms. Okay, so you
here-
brought a 2.5 balloon.
Yeah,
now.
here is clear that in the mid portion is not good result for,
Yes.
for balloon here.
Uh-huh.
So we went to with a 2.5 by
2.5
20.
balloon.
Again, high pressure,
Okay,
even higher in the proximal segment.
okay.
And we want to prepare throughout the entire stented segment. And here is the control angel that we have.
Let's see. Okay, wow, distal.
It looks like within the stented segment a very acceptable result. And
So you still have a total occlusion in the distal part. We cannot see the distal flow.
It's not occlusive.
we
not
think we
total-
have flow, but it's very spastic still there.
Okay, so what's your next?
So the plan now, we think it's good enough to go with the drug-coated balloon.
Okay, what types of drug-eluting balloon do you have here, Ricardo?
So nowadays we have in our institution drug-coated balloons to use in a clinical practice in a case that might benefit from this technology. So we have today the Pantera Lux is a paclitaxel coated balloon that has been.
Is there any sirolimus drug-eluting balloon?
There's already sirolimus being tested. Actually, commercial use already in Europe. In Brazil,
What's the name of the sirolimus?
Magic touch.
we have one called Magic Touch, and another one is called Solution.
Is there
These are
any
two-
comparison between plaque-taxel balloon and the sirolimus balloon?
There are current studies ongoing right now.
Yeah, can you go ahead, please? Because you have maybe in 5 minutes. We'll leave you. We move to lab 1, and you finish. Are you gonna do IVUS after the balloon?
We want to do IVUS.
Okay.
control
So
with
also you're
IVUS.
gonna treat the circ.
We want to treat the circ as well.
Okay.
So here we
Let's
want
see.
to position very, very.
How about the distal wire? The distal tip of the wire is in a good position.
It's in a good position. It's in a whale tail. I don't know.
Yeah.
And then we're gonna use the angel.
So this is a 2.5,
This is a 2.0 by 20,
2.0 by 20.
2.0 by 30. This is a drug-coated balloon.
Only for distal part.
Yeah. So I
So
think
you're gonna use 2 types of drug-eluting balloon. 2.0 and 2.5.
we're gonna do 2.0 and 2.5.
Okay.
For the proximal part.
Okay.
Vai lá, Rodolfo.
I mean 2 sizes. What I mean.
2 sizes, yes. So we use here the stent V's. We are exactly at the distal edge of the stent. And now it's very important. We don't want to achieve an optimal balloon expansion. We want to deliver the drug.
What's
So
the
we
pressure
can go
Rodolfo
nominal
is
here.
giving to this?
6.
Atmospheres. So we need to be so careful with the distal artery that's so small.
So we are.
So for how long do you inflate?
Yeah, the ideal is to at least 1 minute.
1 minute.
Yeah, 1 minute.
It's completely different from the wood balloon because I saw Rodolfo with like the 10 seconds, 15 seconds. Now you delay a little bit more.
Yeah.
For 1 minute.
For 1 minute.
Okay.
If you take the IFU, they say that the minimum is 30 seconds because sometimes you're using in a situation that patient can become very unstable with ischemia, like left main or proximal vessel. But here, 60 minutes is ideal.
Okay.
And some people even do more. We like.
Can
to
you
do
have the
60 minutes,
hemodynamics in the
60
screen,
seconds.
please? Also with the screen, also with the angel. I mean the whole camera, hemodynamics in the down part of. Okay. Now this is the IVUS hemodynamics, please. Great, thank you. Now you see the hemodynamics. The blood pressure is 120. No problem. The heart rate is okay. It's about 77, and we have balloons for more than 1 minute. For how long?
So 1 minute and 30 seconds. So this is more than enough.
1 minute and 30 seconds. So it's treated this segment. Now what are you going to do? Bring it back or
now we are going to go with a second balloon
with a 2.5.
2.5 by 20.
So it's very important what Ricardo is doing here, just for the audience. So the distal part of the vessel is 2.0. And then maybe you can ask me, why don't you use a 2.5 over there? No, because you can oversize the artery over there. The artery over there is about 1.8 or 2 millimeters. The diameter.
2 millimeter
so
diameter.
We use the 2.0 at 6 atmosphere for 1 minute and 30 seconds. Bring the balloon back, and now you're going to use a 2.5
by 20.
Okay.
Yeah.
So are you going to use it also for the proximal part of the LAD, or are you going to use a 3.0 or 2.75?
Yeah, we think we can go with a larger balloon there.
Also,
because
we
the
start
vessel
with
is larger.
6 atmosphere, but go up
by weight, by 80.
14.
14. Okay.
This is a more compliant balloon.
So you use a 14 atmospheres with the 2.0. Yeah. Okay. That's important to mention. The last inflation with the 2.0 was the maximum pressure used was 14 atmospheres. Okay. Now Ricardo is bringing the 2.5 by 20 Pantera balloon, a paclitaxel drug-eluting balloon.
And we want to make sure that you cover all the segments here.
So okay, really so you are in the overlapping over there.
Yeah.
Is that correct?
Yes. We're taking the overlap as
the old overlap.
The old overlap.
Okay.
The same thing now.
Yeah, so you're going up
at
to
least
6?
1 minute. And Rodolfo is going to
6 atmosphere.
And
16.
We are delivering the drug here.
5 minutos eu vou para lá. Por favor. So 1 minute and 30 seconds again.
Yes. Yes.
So in proximal, you're going to do the same.
We want to do the same. One more with the 30 millimeters, because remember, we almost have 70 millimeters of stents here.
So what's going to be your strategy after the second inflation with the 2.5 balloon?
We remove that and we go with a third balloon for the proximal segment.
With a 3.0?
3.0.
Okay. And after that?
And then after that, we're going to do a control angio. We're going to do IVUS. If we are happy with the result, we're going to move to the circumflex.
Okay, good. So I'm going to repeat what Ricardo has done so far. He started the distal part of the LAD with a 2.0 balloon. The mid portion of LAD, he's using a drug-eluting balloon with a 2.5. And the proximal part of the LAD, he's going to use a 3.0. And after this work, hard work, with long inflations that we are not used to anymore, because after deploying stents, we use like 15 seconds, 30 seconds, that's it. So now he's using maybe 5 minutes of inflation. It's important to watch the heart rhythm and also the hemodynamics, the blood pressure, etc. So the patient is just fine.
Stable. EKG is okay.
Yes, she's okay. And after this third balloon, the third balloon used, he's going to do IVUS and a control angel. So I think we have 2 minutes in this lab. And after these 2 or 3 minutes, I'm going to move to the lab 1 to work with the guys there, Carlos, Pedra, and Dimitri, and also Marcelo, to do the structure. That's going to be a very interesting case. I invite you to keep online with us.
3:30. So now we're advancing the third drug-coated balloon into the LED.
Third balloon.
The proximal
2O
segment.
distal, 2.5 mid portion, and 3O proximal. I used to say when we listen to radio, very common here in Brazil, listen to radio. So this we used to see this is rotative audience
Yes.
of the radio.
Yes.
We need to repeat and repeat and repeat.
Every 15 minutes.
Yeah, because the audience is coming. We try to bring you to stay with us. Now this is 3O, Ricardo.
This is a 3O. We just
3O
position
balloon
here.
by 20.
We want to make sure that we are in the right position here.
Yes. So how much pressure Rodolfo did for the 2.5? 14 also? 14. 14.
What's
14
Now he's going to inflate the 3O. So he exactly in the proximal part of the stent. Is there any disease in the proximal part?
There is some diffuse disease, some calcified plaques, but the minimum lumen area it's not in the cutoff that we would consider to treat.
Did you? You did not touch it.
We did not touch that.
Is there any reason to place a drug-eluting stent in this part instead of just balloon, where you don't have a stent or not?
I don't think so.
No.
Okay. Just to leave like this.
All right.
You don't want to cause injury there.
Do you agree with this?
One important thing is to start the inflation with low pressure, very low pressure.
Okay.
To avoid watermelon seed effect.
Okay. That's very important teaching, the point that Rodolfo is just telling us. We want to avoid the watermelon effect. That's common when you treat in-stent stenosis. To avoid this, he starts with low pressure, 1 or 2, and go up after 15 seconds to 3. Don't be rushed to do this. Just do very slowly, because you don't have like a spiral balloon or even a cutting balloon that avoid the watermelon effect. So that's very important. And you want to deploy the drug over there for some time. So Rodolfo, do you agree with Ricardo? If you have some disease proximal of the stent, should we use a drug-eluting balloon or implant another stent with a drug-eluting?
If the disease is severe, okay, but it's not severe. Don't touch.
Let's suppose it's severe.
Severe. I stent.
A stent.
Put a stent.
A stent. Okay. So if you have a severe lesion outside of the stent, the decision would be here to implant another drug-eluting stent. It's important to mention this. So you finish with this. Now we're going to do angio and IVUS. Is that correct, Ricardo?
We're going to do nitro, we're going to do angio,
Nitro
and we're
first.
going to do IVUS, yes. Prepara o nitridil, por favor. And also, this is a very interesting and actually a major discussion right now for if de novo lesions is like back to the past to use a drug-coated balloon instead of a drug-eluting stent. There are some studies testing this in some specific anatomies. I think in the next few years we're going to have some new evidence about this.
Okay, good. Let's see. Are you do angio?
We do angio first, and then we do
angio first, and prepare the IVUS, and I'll leave you here to work in the circ, and I'm gonna be working there with the guys in the lab 1. And after we finish there, I'll come back here. You can take the patient out of the room if you finish, and you can summarize the case.
Okay.
Is that okay for you?
So
okay.
After nitro, you're going to control angio. So within the stented segment, it looks to be a very acceptable result. The distal flow is still not that great. The vessel, I think there is flow, but the vessel is still very small there.
I would ask you to pay attention to the proximal part of the stent, close to that diagonal.
Yeah, and also
how severe was that lesion that was predicting. But let's see the IVUS.
There. Yeah. Okay, let's do the IVUS.
Let's go with the IVUS, and you see this long run, and I'll leave you here to work, guys.
We have free, IVUS free. The image of the diagonal.
The diagonal. Oh yes, you take a look there. Yeah. That's good.
Yeah. And we did some measurements there. It's moderate lesions.
Yes.
Yeah.
I agree with you. I need to protect the diagonal too if you're going to place another stent over there. Is that correct? Do you agree with this?
Yeah,
To
perfect.
protect the diagonal?
Of course, I will do.
Okay.
IVUS imaging, please. Okay.
So may you have the IVUS in the main screen and the angel in the small screen, please? Just to change. Angel goes to where the hemodynamics is, and the IVUS come to the large screen, please.
So we are in the distal portion
Okay,
here.
just wait a little bit, Ricardo.
Yeah.
Oh, no, so may you have the IVUS in the large screen, please?
Deixa. IVUS, please.
IVUS, please.
Vem comigo. Can you have the IVUS, please?
Can you hear me? Maybe they are not hearing us. Maybe you can do the run and we take and we'll repeat later. Okay, Ricardo.
IVUS. Yeah.
IVUS.
So we're in the distal portion here. We see I would say, better size stent to the real vessel size. So better expanded stent in the distal portion. And of course, there's still some hyperplasia there, but the lumen is very well recovered after this pre-dilatation. Wagner, coloca view grande, por favor. Pre-dilatation and the drug-coated balloon. So, Fausto, I think it's a much better expansion. I think that's very clear.
Yes.
Closer to the external elastic membrane. And this is very typical imaging when you do IVUS after balloon, angioplasty, and drug-coated balloon. You're still going to see hyperplasia. Sometimes you see some micro dissections there within the hyperplastic tissue. But this is considered acceptable if you have a good luminal area after your treatment. Of course, where you used to have more hyperplasia, you'd have more presence of this hyperplasia, which is compressed against the stented wall. A recovered lumen area. Here we are in the more proximal part. So already
there is some vibration there.
Yeah, some vibration. So I think we have seen already the stented segment. So from the balloon angioplasty perspective, I think it's a very acceptable result within the stented segment.
So do you have a decision for the proximal lesion?
Yeah, I think we could see the first IVUS run, a primeira imagem do ultrassom. The first IVUS run.
Ela aí, Pri, isso.
Primeiro.
Lá proximal. Pode correr lá.
So, Ricardo, I think for the perspective of a drug-eluting balloon, you got a good result. And I'll leave you to work a little bit more working on maybe the circ or even the proximal lesion. And I'll come back maybe 12:55 to summarize the case in the last 5 minutes. Do you agree with this?
Perfect.
Okay.